Welcome to another CME session from SJMC. We hope you enjoy the content.
Hi, welcome everybody to another CME session for Saturday, the 3rd of December, and this is the 24th SJMC Grand Rounds. I'm your host, Alan Tay for Dobbs, and without further ado, I'd like to bring on the SJMC cardiology and one rheumatologist in the team to give you an excellent and very interesting case presentation. So, all right, so top of the screen is Dr. Ravindran Ramachandran, consultant rheumatologist. Wave your hand, there we go. Dr. Kannan, consultant cardiologist. Dr. Su Lin Ho, consultant cardiologist. And the chairperson and presenter is Dr. Jayamala. Okay, over to you, Jayamala.
Thank you very much, Alan. This is our 24th cardiology grand round, and it is slightly different because we're going to talk about connective tissue and heart disease. There will be three presenters, and the first case is going to be presented by Dr. Su Lin Ho. Okay, Dr. Su, over to you.
Hi, good afternoon. I'd like to present this case when I was called up in the unholy hours of 1:30 by the ER department in Subang Medical Center. They had a 30-year-old man who was complaining of chest pains well over 12 hours, started on the 21st of June at 12 p.m. He presented with vomiting and coughing as well. By the time I got to see him in the emergency department, he was complaining of some pleuritic chest pain and progressive worsening breathlessness. There's a past history of hypertension and also systemic lupus erythematosus with stage 4 nephritis. He was previously seen in a different hospital elsewhere. His medication when presented to us was on prednisolone already, hydroxychloroquine, and Celsep. Next, please. When I saw him in ER, he was very breathless at rest, apyrexial. His oxygenation on air was 90%. Despite having 15 liters high flow oxygen mask, he achieved 97%. His blood pressure was stable, 122/76, with a pulse of 90 beats per minute regular. He had bilateral basal crepitations in his chest and a very noticeable gallop heart rhythm. Next. This is ECG, and I was actually, I wonder whether Dr. Kannan can help me out with having an interpretation on this ECG.
Yeah, but there is obvious ST segment elevation from the precordial V1 to V5. There appears the right bundle branch block pattern 2 in V1, so they're quite well formed two-way V1 to V4. So it's a evolving anterior myocardial infarction, infarction of right bundle branch block. Low prognosis subset. Every function should be pretty up.
Right. This is his chest X-ray, and I think quite a lot of you would detect that it's got a very large heart. There's fluid in the horizontal fissure, and there's some upper lobe diversion consistent with pulmonary edema and cardiomegaly. Next page. So my differential diagnosis, and anybody can help me out as well, was that he had a myocardial infarction and is now presented with left heart failure, possibly pericarditis as well, but there's also possible bronchopneumonia. And in this era, COVID has to be entertained. And there's a background of his history of SLE, and I'm not quite sure whether SLE has any bearing in this condition, but we'll soon learn more. Next. This is his initial test investigation. We have a white cell which is raised with normal differential. Hemoglobin is stable at 13. It has a normal renal function, which surprised me. Potassium 3.3 and sodium 133, nothing remarkable. Glucose was 5.1. CRP was elevated a bit at 12.7. D-dimer, to look for whether the pulmonary embolism might be an issue, is actually not detectable. His troponin was very markedly elevated, and so was his pro-BNP. The COVID rapid PCR was negative. Next. So our initial management to actually stabilize him was giving cruisamide, GTN, gave him intravenous rosafin as well, gave him aspirin and clopidogrel, also subcut taxane, hydrocortisone in view of his history of SLE, high flow oxygen, but eventually even a high flow oxygen wasn't helpful, that we actually had to provide him with CPAP to maintain his oxygenation. This was with the aid of Dr. Lee Pui Kwan, who was an anesthetist at that stage. At this stage, I felt that I really need the help of my colleague in dealing with this case, which sounded a bit, he's quite young, so we really have to try and get him through this very acutely unwell phase. So I've asked Dr. Ramachandran to come in to help me manage this case. So I wonder whether I've got Dr. Ramachandran, who's an expert in SLE, to provide some input.
Thank you, Lin Ho. And there's a few things to be thankful about for this patient and for me in this case. Firstly, at the ungodly hours at 12:30, they call the cardiologist and not the rheumatologist. But from a rheumatology perspective, from a reserve perspective, this was a gentleman. Next, please. This was a gentleman who had an onset of SLE in 2020, a very young man. His initial presentation was actually a skin rash, arthritis, and also was noted to have renal disease at the onset. He had a biopsy done in Kuantan, the previous hospital where he was actually followed up with SLE, and that biopsy formed the report that was provided by his family. He had what the biopsy showed as diffuse proliferative glomerulonephritis, or what we would also call class 4 disease. Just as overview, kidney disease and SLE, there are actually 6 classes. Class 1, which is minimal change disease or very mild disease, right up to class 6, which is actually chronic disease after many years of having SLE. Most patients who present with kidney disease either have class 3 or class 4 being the most common, which is active inflammation of the glomeruli. And he was actually started on therapy treatment that we would probably most of the time give for this condition, which was hydroxychloroquine, which is the background treatment by SLE, prednisolone, initially high dose and subsequent tapering, and microphenolate mofetil or Celsep. Next, please. And when I saw him and when I analyzed the blood results, he had an elevated erythrocyte sedimentation or ESR, which is expected in a chronic inflammatory disease. His C-reactive protein was elevated, which was actually uncommon in active SLE. SLE is one of the few inflammatory diseases where the C-reactive protein is actually low rather than high. So this is actually in some ways helps the rheumatologist differentiate whether the onset of presentation when they come in with fever is due to the disease or an underlying infection. His anti-nuclear antibody, the ANA, which is actually the screening test for lupus as expected, was significantly elevated. His double standard antibody, the dsDNA, which is the confirmatory test for SLE, was also elevated. His complements, which are the proteins, serum proteins that are commonly low in SLE, the C3, C4, were as expected very low in him. We did I did further analysis, given the fact that this was a young man with essentially no real background risk factors for coronary artery disease. suddenly developing what looked like an acute myocardial infarct. So we had a look whether he could have an associated autoimmune condition called antiphospholipid syndrome. And this was actually, and to confirm or to see whether the possibility of him having disease, we do two further serological testing, the lupus anticoagulant and the anticardiolipin antibody, both of which was positive in his case. I decided to assess his severity or assess his degree of kidney disease involvement, and one of which is we assessed the 24-hour urine protein. Most of us would have a 24-hour urine protein excretion of less than 0.15 grams. In his case, it was more than 2 grams. Next. So, apart from the excellent cardiology care that he was getting, I needed to actually make sure that his disease itself was also well controlled. So we optimized his steroid dose, switch him to an injectable form of steroid, which would actually would be actually be able to stabilize or smoothen his amount of steroid that he gets. Continues his hydroxychloroquine, the importance of which in this context I will actually probably discuss a bit later. He was on a slightly sub-optimal dose of CellCept, which is the definitive treatment that we give for his kidney disease. So I optimized the CellCept dose. And the concern about the elevated C-reactive protein, in his case, there could be two causes for it. He could have coexistent infection. The X-ray did suggest some evidence of pneumonia. Of course, the CRP could also raise, as Dr. Su would probably can also comment, in patients with an acute myocardial event. So, but just to ensure that in a person who's immunocompromised with like him on multiple immunosuppressive therapy, so I decided to start him on IV antibiotics also to cover for possible infection. Next. Okay. How do we diagnose SLE or lupus? We now use a new criteria from the American College of Rheumatologists and the European Association of Rheumatology, the ACR and EULAR criteria. And in patients, all patients who are deemed to have SLE must at least have a positive anti-nuclear antibody titer of 1 in 80 and 10 points from the criteria that the different clinical and immunological domains that I've actually listed below. Next, please. So in this patient, his clinical domains that were present were he had fever, he had significant proteinuria, and he had biopsy evidence of class 4 lupus nephritis. And he also had multiple immunological criteria fulfilled. His antiphospholipid antibodies were positive. He had low C3 and C4, and his anti-double-stranded or anti-dsDNA antibody was positive, all which accumulated gave him a 28 points, which is actually essentially Bandor SLE. Next. Okay. Maybe just a few slides on what antiphospholipid syndrome is. It's a condition, it's an immunological condition where there is a thrombotic tendency, either a venous or arterial thrombosis, or occurrence of microthrombi, most commonly presenting as placental insufficiency in young women with this disease, resulting in recurrent miscarriages. You must always have the presence of one antiphospholipid antibodies confirmed by 2 different tests and repeated or reconfirmed, persisting with a repeated test after 6 weeks. Next. So in this patient, we confirmed the coexisting antiphospholipid syndrome because he had at least one laboratory criteria. He had in fact 2, lupus anticoagulant and the anticardiolipin antibody positivity, as well as we assume an arterial thrombosis, which actually resulted in his acute myocardial infarct. Next. Okay. Dr. Su, back to you.
Okay, thanks. I felt really reassured having Dr. Ramachandran on board dealing with this case. And this is the echo, as quite a lot of people shouting out, "Where is his echo?" Now this is his echo, and I'd like to actually invite Dr. Kannan to comment on this echo picture that I've can you let it run again?
Yeah, running very well, but so I try to let it run. Yeah.
Running.
I'm not running.
Anyway, yeah, this is left ventricle that you see mainly in the picture. You can see that the distal portion in particular is more hypokinetic. So essentially that's reduced left ventricular function.
Okay, now this is a picture which I'd like to introduce you to one of the latest AI technology that we have, echo using speckle tracing. This is computer generated, and we have an ejection fraction which is projected by the computer, and it tells you that straight off its ejection fraction is very poor, 33%. We now have these facilities in our within the establishment here. Next, please. Now, I'd like to share with you how drastically unwell he became. Shortly, he was very tired. His oxygen saturation got reduced to 91%, at which stage, very shortly after, the decision was made to intubate him and ventilate it. Before that, we actually stopped his IV GTN. Expectedly, his blood pressure on intubation ventilation with propofol, his blood pressure dropped to 89/70, and we started some inotropes, noradrenaline and dopamine, and that successfully brought his blood pressure up. He was febrile the following day, and we changed his IV rosapine to tazocine on advice by Ravi. And unfortunately, the next day he actually became more awake and self-extubated. Fortunately, he actually didn't have to be intubated again because his oxygen saturation was maintained. The following day, he had an episode of SVT, which was easily terminated with IV amiodarone. We only managed to perform a cardiac catheter the following day when he's more stable. And this is his cardiac catheter study. I'd like to invite Dr. Jaya to comment on this.
Okay, I think you can see that this is, in this view, there's an LAD, left anterior descending artery, coming down. The flow is very slow, but it goes right down to the tip. Now, the other thing that you will probably notice is there's a little bit of staining here. There's no obvious plaque, but there's a bit of staining here, which is suggested that maybe there's an ulcerated plaque at this point.
Okay, next patient. Now, this is just to show that the other arteries, the circumflex artery and the right coronary artery, is completely normal with no obvious obstructive disease. So, in summary, we actually have this young man with acute myocardial infarction with a non-obstructive coronary artery disease. He also has acute left ventricular heart failure and has SLE with nephritis, a very complicated issue. Next slide. So, what is MINOCA, which is myocardial infarction with no obstructive coronary artery disease? This is a conundrum of condition which only represent about 5 to 10% of all acute myocardial infarction that we see. The first one is actually a spontaneous coronary artery dissection. This is usually found in females. We don't quite understand why it is, but there is actually a relation with hormones, systemic illness, and also stress as well. The etiology is not known, but we do see spontaneous coronary artery dissection as part of this conundrum of syndrome. The second is coronary artery vasospasm, and this is commonly seen with people with cocaine abuse and drug abuse, which can cause coronary artery vasospasm and also myocardial infarction with no obvious obstruction. Microvascular disease is a very rare condition, involve all the small arterioles. This is part of syndrome X, and actually they can itself get a myocardial infarction result from the small arterioles. The other well-known is stress cardiomyopathy, alternatively called broken heart syndrome, Takotsubo. Takotsubo derived from using the Japanese uses the track for octopus, and they actually form a bulge. Now, this condition seems to be associated with stress induced, either something has caused them to be a very upset, stressful situation, and they actually have a myocardial infarction, presumably a lot due to the adrenaline that they actually produce from the stress and other conditions as well. And the last one is myocarditis, and this can be a cause of myocardial infarction with no obstruction. SLE can cause myocarditis by itself as well. Majority of these cases of INOCA, actually, there's a predominance of females in that condition itself. Now, I'll go next. Outcome. This guy presented later on have hematuria, and that causes quite a lot of complicated management with him, because we had to stop his thrombotic drug and Klaxin as well. Fortunately, when we were seen by our urologist who evaluated him and the condition settled, Dr. Bauer syndrome actually eventually discovered this is actually possibly traumatic from the catheterization that he had. He had also palpitations, which were seen to be ventricular ectopics and no dysrhythmia of other kinds. He had also acute kidney injury, renal function deteriorated, and we had to ask a nephrologist to come and give us an idea whether this could be SLE or other causes. I think we actually found that kidney injury is presumably due to the hypotension episode that he had when he was intubated, and this seems to have recovered quite well. The lupus anticoagulant issue has been dealt with by Dr. Ramachandran. We restarted dual antiplatelet agent on the 2nd of July, and we added a NOAC on the 4th of July. NOAC being the novel and oral anticoagulant. We used apixaban in this case. Fortunately, we were able to discharge him on the 4th of July. When he was reviewed in the clinic by Dr. Jayamala when I was away, he was back to work but not flying, and he could walk very fast. And his medication consists of spironolactone, Jardiance, Coplavix, apixaban, and Trestol, atorvastatin, bisoprolol, prednisolone, Celsep, and Paconum. When he was seen by Dr. Ramachandran in his clinic on the 8th, he felt much better and had no issue. At this stage, I would like to invite Dr. Ramachandran to comment on how his progress and how his future management should be.
I think this case, actually illustrates the benefit of multidisciplinary care in such a complex patient. And I think he eventually, through all the storm that he went through, he actually had a very positive and a very good outcome finally. And I continue to follow that in on a monthly basis, and his latest review was in October. And at that stage, if you do remember his results from before, now on his latest laboratory testing, both his ESR and CRP had all both come back to normal. His serum albumin, which was actually in the mid-20s, had also come back to normal, illustrating that his kidney disease has improved. His complements, which in well-controlled lupus actually had normalized. And now his random urine protein, which was actually, we actually graded as negative, phase 1 to 3 plus, which was actually 2 plus when he came in, was now negative. His latest review, his health, he was in excellent health, good effort tolerance, he was back to his exercises. And I think on further history taking, one, he had recovered from his acute episode. he actually confessed of not being very compliant to his treatment, slightly irregular followed up with his previous nephrologist that he saw for his kidney disease. So now he was actually much more compliant. I think sometimes a good health care actually illustrates the importance of taking your medication, and he was now very compliant and also and this very important, positive about the progress. I mean, I think healthcare is a two-way thing now, and we need patients also to be proactive in their treatment. So in terms of moving forward, in terms of his treatment, I think the key thing for him would be optimizing his disease control, because we know there's numerous research that suggests that poorly controlled disease activity is one of a non-traditional, we would say, risk factor for heart disease in patients with SLE. So optimizing disease control is important, as well as, of course, with the cardiologist's help, controlling his other CV risk factors. And one of the important terms of treating him moving forward would be to try to reduce his steroids. I always tell my patients that steroids is your short-term friend, your long-term enemy. So we need to actually try to reduce the steroids to actually, as steroids actually affect glycemic control, affect the blood pressure, affect the lipid metabolism. So we will try to reduce his steroids. Now, I've brought down his steroids now to about 10 milligrams. And of course, continuing his other medications is if we are going to reduce steroids, we need to actually control disease, which is more what we call safer long-term immunosuppressive therapy with his CellCept and his hydroxychloroquine. And the other important question about this is anticoagulation. Generally speaking, patients who have anti-phospholipid syndrome, who have had a previous, what we consider life-threatening thrombotic event, we would actually prefer to maintain anticoagulation indefinitely, and this is what we are doing with him. He's on one of the newer Epizaban, one of the newer oral anticoagulants. So, and then we hope with this that he will not have any other events, and his future health issues will be a bit more smooth sailing than what happened during this episode.
Thank you, both Dr. Su and Dr. Ravi. It just shows the importance of a multidisciplinary care. Young men, 30 years old only, wet connective tissue disease, and a very life-threatening situation where he requires intubation. And surprisingly, he has done quite well. In fact, the last he did 10 minutes on the stress test. Okay.
Can I ask a quick question? What is latest ejection fraction?
The last is about 40%.
Good.
Yes. The next second case is by Dr. Kanan. And again, Kanan, over to you.
Yeah. So this is a patient we saw long ago. She was then 40 years old. It is September of 1997. She was referred to me at the Asasa Hospital. She had presented with a 4-week history of chest pain and exertion, which was relieved with respite classical. And then 2 weeks of leg edema, orthopnea, and paroxysmal. The clinical examination and chest X-ray was reported as showing classical heart failure. Those notes are no longer available but more than 20 years ago. The risk factors identified in the records were impaired glucose tolerance. She also had a strong family history of premature coronary artery disease, and she had the old ECGs have all faded, but the ECG done quite recently in August of 2022 looked similar to the ECG that she had right at the beginning. And next, just hit the button again there. Just go to the next slide. Okay. So I thought I'd invite Dr. Su to comment on this.
This is an ECG, which is regular sinus rhythm, and the first offhand obvious thing is actually there is Q waves noted in the inferior leads, which is lead 3 and AVF, and also in the anterior septal leads, which are V1, V2, V3. There appears to be probably a previous infarction in the area. There's poor RV progression in inferior leads, so there may be also an event in the past. you can note a slight SC depression noted in lead 1 AVL. So they may be all suggested that ischemia or previous infarct has been affected with the CCJ.
The ECG already tells us that she probably has multivessel disease, old anteroseptal and old inferior infarction. Next slide. So we went on to do her angiogram. This is October of 1997. And as the diagram illustrates, quite extensive triple vessel disease, especially the right coronary artery with collateral formation. So all this has been going on for quite a long time. Next. So about 2 weeks later, she was referred to our hospital for coronary bypass surgery. But upon her arrival, she reported that she was febrile. She also had been anorexic since the angiogram was done. So clinical examination suggested some dehydration. There was postural hypotension. The BP was 120 by 80 sitting and 95 by standing. A pulse rate was 80 per minute regular. The rest of the clinical examination was reported as unremarkable. So we did some blood tests, and the hemoglobin is a little low. The ESR is quite markedly elevated. So is the urea and creatinine, and this had been normal at the Ascenta hospital earlier. Potassium was actually quite elevated at 6.7. I invite Dr. Jaya to comment about the biochemistry.
Two, as you have pointed out quite rightly, she's hypotensive, and dehydration itself may have caused the worsening renal function. Maybe she also has an underlying renal pathology which has been aggravated by the insults she has received so far, the hypotension and the contrast.
So, like Dr. Jamal pointed out, we agreed with all the thoughts. The only thing unusual about contrast nephropathy is usually when patients develop contrast nephropathy, to start with the renal functions are normal, and then so this lady was normal when she started, so that's been unusual. So we thought dehydration was certainly on the card and something that we could treat. Next slide, please. So we decided just go back. One slide. So anyway, we decided to stop diuretic therapy. Next slide. We did an ultrasound, and this did not show any evidence of obstructive neuropathy, which is very important. It's a physical thing that you need to do something to relieve the pressure in the kidneys. But the renal parenchyma was reported as showing diffuse increased echo density, suggesting that that's parenchymal disease. So all diuretics were stopped, and then she was seen about a week later, and she came complaining of nausea and vomiting. So we thought the renal function had actually got worse. Physical examination, blood pressure was all right, the heart rate was all right, but the biochemistry had actually significantly improved. And we did a few other tests because of the elevated ESR, and that's out there for you. The antinuclear factor was positive. So we thought we'd invite Dr. Ravindran Ramachandran to comment on biochemistry and what he saw as likely.
The findings of just one slide back, please, Dr. Jaya. You see, this is a lady who had no previous history suggestive of an autoimmune disease, came in with predominantly cardiac manifestation, and I think what triggered her physicians at that time to Dr. Kannan and the other physicians to do this test was the fact that she had an unexplained worsening of her kidney function. And the blood test, the chemistry, the serological tests, you have your anti-nuclear factor positivity, anti-double-stranded antibody positivity with low C4. This would suggest that what the patient has actually SLE, systemic lupus erythematosus, with a possible lupus nephritis, which is involvement of SLE in the kidneys. I think it's very important also to actually illustrate or just explain that in autoimmune diseases, unlike some other diseases, the serology is an adjuvant or help to make a diagnosis. It does not confirm a diagnosis. You must have clinical features to suggest that you have that particular disease before making a diagnosis. So we normally go back to the diagnostic criteria and see whether she does actually fulfill the diagnostic criteria. Maybe we just go back to the previous slide. We'll leave it here. The only other thing surprising in terms of kidney involvement was she had no previous history suggestive of an immune disease or any kidney involvement, but the ultrasound already showed that she had chronic parenchymal disease. It would mean that the insult to the kidney has been going on for some time, either undiagnosed, whether it was related to autoimmune disease or another pathology is very hard to say at this stage. And this is where if the diagnosis, the underlying diagnosis is in doubt, where a renal biopsy would be helpful to help us confirm the diagnosis or the cause of the kidney involvement. So just one or two slides about SLE, just very briefly. SLE or systemic lupus erythematosus, SLE, is actually the most common systemic multi-system autoimmune disease that we see, are the most well known. It is actually it's a disease that presents with initial flares. With treatment, they go into remission, but because the chronicity and the nature of the disease, they can have frequent relapses. It's a very heterogeneous disease. It has replaced syphilis as a great mimicker. It can actually present with many different organ involvement. Because of the heterogeneous nature of the presentation, sometimes diagnosis can often be missed, delayed, or difficult to be made. Because it can affect any part of the body, although most commonly affecting the skin, joints, and the kidneys. Even the heart, lungs, and the central nervous system can also be involved. Next slide, please. Okay, that's just a bit of demographics of patients with SLE. As you all are all quite familiar, about almost 90% of patients who present with SLE are women. The Native Americans and African Americans are most common group, have a highest prevalence of SLE among the community in our neck of the woods. It's slightly more common among the Chinese compared to the Malays or the Indians in Malaysia. And the most common age to develop SLE is mainly women in the reproductive age group. So that's what makes the disease so devastating. It commonly occurs in people, in women in the peak of their lives when they are actually getting married, having children. So that's what makes it a very important a condition that we try to actually diagnose early and treat quite aggressively. That SLE, not all patients develop severe SLE. About half of them have a mild to moderate form of disease. Only about half of them have actually what we call organ-threatening or life-threatening disease. Okay, this is the similar diagnostic criteria that we used to help us make the diagnosis with Dr. Su's patient. So shall we just apply the criteria? Well, her anti-nuclear antibody was positive, and we don't have all the data because it's the case from some time ago, but we know that she had kidney involvement, renal involvement, she had low C3, and she had a positive double-stranded antibody, all amounting to 13 points, which crosses the threshold of 10 points that we need to actually reasonably make a diagnosis. Dr. Kannan?
So, thank you, Ravi. So she continued to have intermittent chest pains, both at rest and exertion, and these were the medications given to her. But you must remember that she was treated 20 years ago. So we didn't have some of the drugs like ivabragine in 1997, and with the diagnosis of lupus, prednisone was started. Then in January of 1998. While we were waiting for the disease to settle, she was admitted with more frequent chest pain. Blood pressure was S on the side, and no heart failure signs. So I think one more. Yeah. So the investigator, we found that hemoglobin was 10.4. So we're going to ask Dr. Su, what would you do in a patient like this? Because the lupus is not controlled, the patient is not, the surgeon is reluctant to operate, the patient still has got chest pain. And if we thought that anti-angina treatment was considered optimal, what else left?
Thank you. First of all, it looks like there's a lot of anti-angina medications already on board. That raises a question whether she does take or comply to all any of the medication at all. I think going back to seeing her pulse rate was actually around 80. That also possibly suggests that the beta blockade wasn't adequate enough. In those days, we tend to try and give maximal beta blockade to try and get the heart rate down to 60, and that may actually help. In this case, the hemoglobin is 10.4, a bit low, less than the respect of 12. And normally at this stage, we're wondering what kind of anemia this would be. I would have actually checked the serum iron profile at that time to determine whether iron deficiency is the cause of this. Now we have other new medications now as a laboratory that we could actually use for anti-angina treatment. So that is my point of view at the moment, and whether compliance, beta blockade, investigate what kind of anemia this was.
So what we decided was that she was complying to medication. We felt that the hemoglobin was a little low. We thought that we give her a bit of blood, prop it up a bit, control her ischemia. That's what we did, and the angina was controlled, and she could wait for a month, by which time the investigation indicated that the glucose was under control, and surgery took her on, and bypass surgery was done. It's been 24 years since the bypass surgery. She still comes to follow up. She has put on a lot of weight because of steroids over the years, but she is stable.
In this day and age, would you have considered multi-vessel angioplasty?
For what we saw there, it was very diffuse, very extensive. So I think putting in long stents, multiple stents might not be a good idea. I think in this lady, such diffuse disease bypass is the way to go. And for her 24 years, I don't think stents would have done that, even now.
In this case, what kind of antiplatelet agents would you give any anticoagulants with regards to the treatment of this graft and SLE?
I think she was not from the serology testing, she didn't seem to be antiphospholipid antibody positive. I mean, there's a few things from the rheumatology point of view in terms of cardiac management moving forward. I think as we mentioned the case before, optimizing or trying to reduce the steroid dose as much as possible would be something that we would be keen to do. Another important thing is the role of hydroxychloroquine. I mean, I think very underrated treatment. In patients with SLE now, hydroxychloroquine is considered a standard care treatment. We use it to treat mild SLE, and we also use it to prevent long-term relapse of SLE. We like to use it in patients who are pregnant, so they do not have a relapse during their pregnancy. But as more research has been done on hydroxychloroquine, we now find that it has other beneficial values, especially in patients who have SLE, who have associated coronary artery disease. It has anti-thrombotic effect. It also has lipid stabilizing, and there's some evidence to suggest that it helps with glycemic control. So I think that there is actually all patients with SLE, we now actually put them on hydroxychloroquine. And I tell my patients, even in SLE patients who are well controlled, who are in remission of poison disease for many years, we still keep the hydroxychloroquine on board, not only to help with the SLE. We know now that the most common cause of death in patients with SLE, because treatment is so good, and because we better manage our immunosuppressive control. Previously, the most common cause of death was infection or active disease. Now, the most common cause of death is actually due to cardiovascular events. So, the long-term steroids result in poor glycemic control, increase in weight. We know patients with SLE have insulin resistance, more likely to have insulin resistance. So actually, the most common cause of death is mainly for major adverse cardiovascular events. So actually, it has actually been shown that Plaquenil does help to reduce that risk somewhat, apart from obviously controlling or just managing the traditional risk factors.
Thank you very much, Dr. Ravi. So the first case, the young man who had SLE and then presented with acute myocardial infarction and heart failure. Second case is someone who presented with cluster angina and heart failure, and in the process, while being worked up for surgery, was found to have SLE, which therefore had. Now, this is a third case, which is a very short case, but it is another unusual presentation of connective tissue disease. 51-year-old lady who just comes in because of rashes on the lower limbs associated with some chest pains. Just 2 days earlier, she had actually taken in some Yakult, which was expired by 2 weeks, and she thought it was all due to this. She had diarrhea, abdominal pain, there was no blood in the stools, and by the time she came to see the rheumatologist, she had no more diarrhea, although she still had abdominal pain. For about a week, she had noted some rashes in both her legs and knee pains. Initially, she also had wrist pain and swelling of the left wrist, but that subsided, and now she only had knee pains. The rashes were sudden in onset, felt itchy, and it was only there for the last 1 week. No fever, previously well, couldn't eat much because of the abdominal pain due to the Yakult, no history of fatigue, no other joint pains previously, no mouth ulcers, no hair loss, and no past medical history or family history of note. Relatively healthy 51-year-old. She came in, she was afebrile, she had no facial rash, but she had what looked like a non-blanching vasculitic rash up to groin and thigh, dorsum of feet, she had blisters and scabs. Her upper limbs were spared. BP was 122/78, heart rate was 70, abdomen was soft. Both knees were slightly tender and the right knee was slightly low. So the first rheumatologist who saw her, Dr. Haslin, thought she had a vasculitis and she queried whether it was due to an infection. So a CRP was very high, as Dr. Ravi had pointed out. The CRP is high, maybe there's an infection. And so C3, C4 was actually normal. Extractable nuclear antigen was negative. Anti-DNA was normal. ANA was 1/320. That was elevated, which I believe is 1/80. Anything above 1/80 was positive. The anti-neutrophil cytoplasmic antibody, ANCA, was negative. So the skin biopsy was consistent with vasculitis. It appears that she had vasculitis and she had an ANA which was positive. Now the very next day after admission, she had left flank pain, which was continuous. It was referred to the gastro, and because of the history of vasculitic rash, he suspected that she might have maybe vasculitis in the abdomen, and he ordered a CT scan. Now, this CT scan, which is on your left, is her CT scan, and the one on the right is the normal CT scan. So, Dr. Ravi, can you sort of maybe want to comment about this CT scan?
Okay, what strikes me from the CT scan is the significant submucosal edema of the small bowel, and there's some evidence of actually uptake from the contrast. So you see, when you have significant submucosal edema and contrast enhancement, this is in keeping, especially small bowel, it is keeping with enteritis. And when we see this, there are two possibilities: whether this is actually could be infective. For me, I feel that the extent of involvement is too significant, quite extensive to be explained just based on infection. And the second, of course, whether this is an immunological cause. And I think that would be the likely cause, given her context of having cutaneous vasculitis and evidence of arthritis, other symptoms and signs suggest an autoimmune disease. So this would likely be to what we would see in similar to in mesenteric vasculitis. So I would say an immunological cause would be more likely than an infective cause.
Surgeons who saw her said that the treatment will firstly be medical, and only if she had gangrene or severe pain, then we will have to think about surgical option, which is basically resection. So she was started with IV without prednisolone, cyclophosphamide, and azathioprine, which I believe are all immunosuppressants. And she did quite well. The stomach pain, everything settled. And she was discharged on the 25th. She was admitted on the 8th and discharged on the 12th. Less than a week later, she was readmitted. She had actually gone to the toilet to pass motion, and it was fresh blood, and she fainted on the floor. She brought to ER. She was pale, BP was low, there was tachycardia, and she had fresh melena. So she had the diagnosis of bleeding per rectum. The HB was 5.7 at admission. The total white count was 37,000. Platelets were normal. Her liver function test was okay, except her albumin was low, and the renal function was okay. I must commend the ECG. She had no chest pains. She had no difficulty breathing, just that she was feeling very weak, and the ECG, the MO in ER did an ECG. Dr. Su, can you please interpret this ECG? Okay. This was the ECG done in ER.
This looks like a tachycardia, and is abnormal looking, with marked ST depression noted in the anterior leads. Wonder there is actually prominent R waves in the anterior leads as well, raising a possibility that this could be a posterior infarction. If you revert it upside down, you may be able to see an ST elevation there. But it's actually abnormal, and ischemia there is a predominance of it. I think from looking at the baseline, it is in sinus rhythm, although it looks a little bit irregular a bit, but I think it's in sinus rhythm. So that's my comment. It's actually a ischemic ECG, possibility of even in a posterior infarct.
Remember, her HB was 5.7, and so when I looked at it, we thought maybe it was just severe myocardial ischemia. Trough T, the first day was 240, and the next day it went up to 3,000 with an elevation of CKMB of 96. 51-year-old lady with no other risk factors. By the third, the next day, her ECG actually looked normal, but her trough T and CKMB were high. So this was the echocardiogram done, and I'm not sure, I hope Kanan can see this. This is the parasternal view.
I think we have seen this before, but in the interest of time, I think the inferior segment looks very hypokinetic as compared to the other LV segments. We can point out the arrow where the inferior segment is.
This is not very severe hypokinetic. So there appears to be regional marginal wall motion abnormality. It was not a global thing, which would be in keeping with a myocardial infarction in a 51-year-old. The next day, they did a scope, and basically they just found there was no active bleeding points. It was just small bowel bleeding. And she was given a total of 8 pints of blood. Bleeding stopped. She was started on CellCept. She had no chest pains during this period of time. So now this is a dilemma of how to manage this lady. She had come in, she has got an infarct, probably a myocardial infarction, but you can't give her any of our usual antiplatelets because she was bleeding like crazy. She had no chest pains. Her BP was low. You couldn't even use beta blockers. So when she was much more stable, I actually asked to do a CT coronary angiogram just to see the extent of her disease. You may not be apparent, but this is the right coronary artery. She's probably got a thrombus here and up here as well. Severe narrowing. And even on the left side, you see a lot of calcified plaques and diagonal all have disease. So she looks like she has multi-vessel disease, which raises the possibility that her connective tissue may be much longer than 1 month. Okay, so Dr. Ravi, can you tell us, is this really SLE or what kind of connective tissue are we dealing with here?
See, when you first presented this, you see at first glance, I would have actually probably made the diagnosis of Henlock-Schönlein purpura because she had short history, what was suggestive of abdominal or gut infection, and subsequently there are rash, arthritis, and colitis, which all is keeping with what you may get with Henlock-Schönlein syndrome. The serology was relatively unremarkable. You see, her only abnormality was actually the elevated CRP. In this case, would be in keeping with an inflammatory condition. Elevated ANA. ANA is essentially a screening test. It's not a confirmatory test. The titers were not very high, and sometimes in patients who have an immunological condition and a sudden immunological presentation, you tend to actually produce all what we call this autoantibodies, and you may get a non-specific increase in a titer. So she doesn't really fulfill the criteria for SLE. But having said that, Henlock-Schönlein purpura is a post-infective condition, and it's a condition that is most of the time self-remitting. It actually gets better or remits with treatment. But looking at what you've shown from her coronary angiogram, this looks like a disease that's been around for much longer. If there's no other explanation, no likely explanation that she doesn't have any other the traditional risk factors for coronary artery disease, then we would think whether this is actually a form of collagen vascular disease that would have contributed to the coronary. And looking back at if this is not lupus, what could it be? I'm just thinking whether this could be a form of a small or medium vessel vasculitis, something like polyarthritis nodosum, or maybe not so much vagus. Vagus does not influence the coronary so much. Maybe a middle vessel vasculitis that may contribute, that may actually be able to tie up all the pieces together in this case. And even if she does have the disease, then the treatment that she was given would be appropriate. She was given cyclophosphamide and then put on steroids. So the treatment would be that type of immunosuppressive therapy, and she's now on CellCept. So that would be the way forward in treating the medical side of a collagen vascular disease. So, but I agree with the dilemma. What would you do with the coronaries now that you can't give any antiplatelets or the risk of the antiplatelet therapy with her? So that I think that would be a bigger dilemma. In terms of treating her presumed autoimmune disease, she's already on the appropriate therapy for that.
So the learning points from today's grand round is that the heart will be involved in many ways in connective tissue diseases. Of course, it can affect the valve leaflets, coronary arteries. In fact, all 3 cases have coronary artery involvement. But pericardium, the myocardium, conduction system, and everything can be involved in different degrees of severity. The cardiac involvement, as Dr. Ravi says, contributes significantly to their morbidity and mortality. However, it is often underdiagnosed, and the pathogenesis is highly variable. It could just be vasculitis, it can be due to thrombotic events, whatever. With that, I would like to pass it back to Dr. Ellen Kay.
Thanks, Dr. Jamala. And let me get everybody on the screen. It is actually question and answer time. I'm looking at the YouTube comments. No questions. And also Slido.
Very clear, I think, to everybody.
No, either everybody is crystal clear or overwhelmed. I have a I have a question in a sense that I mean the main thing I learned today, as they say in internet, TIL, which stands for Today I Learned. TIL, the term Minoka. So I'm sharing this one. Yeah, this is new acronym. I think if you don't know anything new, we just create acronyms. So how? I suppose most of our SLE about 10-to-1 female predominant, isn't it? So if we see myocardial infarction in SLE, it's likely to be Minoka rather than atherosclerotic. What do you
say? The lady that I showed last was atherosclerotic.
So we can't assume it's Minoka also.
But I think it is interesting in actually Professor Kannan and Professor Jayamala's cases that it seems that they seem to have had maybe low-grade or smoldering disease for much longer than when they presented. Dr. Kannan's case, they only had parenchymal kidney disease. Dr. Jayamala's case, they only had atherosclerotic disease at presentation. So, I mean, it just probably underscores that these diseases sometimes don't manifest itself in such an obvious and acute presentation, and but it's still working its way, and in a very low grade way, has actually caused a fair bit of morbidity.
Well, I think a very interesting set of patients. I think such a diverse presentation is something you must think of. I suppose we cannot dismiss chest pain, somebody with collagen disease, myalgia or costochondritis or something. Actually, they're young. The young man also is quite interesting. They may not be totally classical myocardial infarction. Okay, I've been asked to share this. Hang on. Share this symposium. Maybe Dr. Jamala, you want to?
For our next grand rounds in January, we are actually having a hybrid event. It's on the 8th of January. And as Dr. Ellen has shared with you, it will be at Hyatt, and it will be a one-day session. And you get about 8 points, one shot. So you can either attend face-to-face or can be virtual.
How can they register? Can you see the QR code at the bottom? It's a bit small. I don't know if they can scan. Let me check.
With cards, you can contact the marketing department and SJMC or Viatrix, and they will be able to help.
Let me try to blow it up. It's a full-day session, yeah?
Yes. You get 8 points.
Okay. Is it big? Okay. Yeah. I think she will scan and register. Okay. Yeah. Right. So, any other comments? Nothing. Okay. I think Yeah.
important.
Okay, and Jia has said that she's already sent an email blast to the GPs. I think, yeah. Okay, I know everybody is waiting for the QR code for the point, but let me please share a reminder. Yeah, today is only my virtual self, so you're not seeing me.
Thank you for watching our video. If you enjoyed the content, please don't forget to hit the like button and subscribe to our channel. Also turn on notifications, so that you won't miss our upcoming videos.
Younger version with more hair. Yeah.
Get out of medical school and starting his medical career.
Please do subscribe to our channel, because we still get people asking us how to watch, and when's the next one. So if you subscribe and hit the notification bell, YouTube will send you a reminder that this is coming up. Okay, I'm going to show the QR code now. Let me see. Okay. So that's in the background. Oops. Wait. Let me check the please. Oh. Okay. Let me see. Nope. Okay, give me a second now. Let me share the slide. Okay, the points will expire roughly about an hour or less. So please scan as soon as you can. Let's check and see if it's working. Okay. It's now December, so you still have another 6 months to accumulate 20 points.
Come for the January meeting,
Yeah.
8 points.
8 points, yes. So every point is precious, especially those who don't have time, especially busy GPs who don't have locums. I think these sessions are very useful for them. And I think case-based presentations are always very more interesting than just didactic lectures, I think. So, all right. So thank you, everyone, for today's excellent session. And I think it was great learning. And we'll see you again in January. So don't forget the hybrid event. If you, for the GPs who are keen to attend either virtually or in person at last, okay, post MCO in Hayat Saljana. So please contact JR, our GP liaison, okay, at see you in January, either in person or online. Okay, have a nice day, everyone. So we're going to end the broadcast now.
Thanks a lot.
Thank you.
Thank you.
It was a nice session.